The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of Inside JACC, and I'm talking to Dr. Tony Bavry. And Dr. Bavry is Assistant Professor of Medicine at the University of Florida and the senior author on a very interesting paper about to be published in JACC that deals with the use of statins before cardiac procedures. Tony, tell us about the study you did. It was a meta-analysis.
Correct. This was a meta-analysis of 21 studies in 4,800 patients. We looked at the use of statin medications before invasive procedures, and we documented a significant reduction in myocardial infarction after these procedures.
Was that all procedures, or was it better for PCI than for surgery?
So there was a significant reduction overall, but this benefit was seen within the PCI cohort and also in the non-cardiac surgical studies as well.
So when you do a meta-analysis, the studies differ, of course, what statin was given, how long prior to the procedure. Was there anything found about the time interval prior to the procedure that was critical?
You're right. In a meta-analysis, there's often differences in the study design, the use of the medications. For the PCI studies, it was usually atorvastatin that was used at a dose of 40 to 80 milligrams. For the non-cardiac surgical studies, it was fluvastatin at a dose of 80 milligrams, and that was given 4 weeks before the surgical procedure.
So do you think there's something magic about atorva or fluva, or do you think you would have gotten the same results with any statin?
That's a good question. I think that deserves further study. Atorvastatin is a more potent statin, so it would stand to reason that would confer more benefit, but this study does not address that question.
Was there anything about the dose? What dose should we use if we're going to pre-treat our patients?
For PCI, we are currently using 80 milligrams given...
80 milligrams of atorvastatin.
Correct, 80 milligrams of atorvastatin given the day before the procedure. For non-cardiac surgical procedures, it would have to be fluvastatin, 80 milligrams, but that's a less commonly used statin in the United States.
Sure. So you think it's got to be 80, or you're just doing that because you think that's the best dose?
That is the weight of our analysis. For the PCI cohort, it was 40 to 80 milligrams. So if there would be concern with some toxicity with the statin, 40 milligrams I think would be reasonable. But for most people, I would go with the 80 milligram dose.
Now, does it matter what the LDL is? Does that have anything to do with the benefit?
No, I think this benefit is independent of LDL lowering. So LDL lowering takes several weeks to occur. I think this benefit that we're seeing is due to the pleiotropic effects of statins. So we do not check the LDL level of the patient. We give the dose of statin regardless of what their lipid profile may show.
And what about evidence of inflammation? Does that make a difference?
We know that statins reduce inflammatory markers, and that may be part of the mechanism by which this benefit is seen. We're not testing for inflammatory markers, but we know that these medications do reduce the inflammatory markers.
Now, how about if the patient's statin naive versus already on statin? We know for the recapture studies, reload studies, that even in patients who are chronically on statins, giving an extra dose seems to be a benefit. Did you find that as well?
And most of the patients in our analysis were statin naive. They had not been on a statin medication. You're correct with the Armida recapture study. They were on a statin medication and then they got reloaded with a very high dose. So if our patients are statin naive, we're giving them a high dose of statin medication. If they're on a moderate to high dose of statin medication, we're usually continuing that dose. But based on the Armida recapture, I think you could also give them an even higher dose going into their procedure.
Well, increasing evidence that pretreatment with statins really can reduce events if given prior to cardiac procedures, particularly myocardial infarction. No evidence in terms of mortality just yet. Some benefit in surgical patients for reducing postoperative atrial fibrillation. It's clear that perhaps in contrast with beta blockers, which were once thought to be tremendously valuable, that statins probably are here to stay prior to procedures. For Inside JACC, I'm Tony DeMaria.